OPB-11077 is a novel oral low molecular weight compound that has been shown to inhibit mitochondrial electron transport. The rationale for the study is that patients who are treated with Decitabine and Venetoclax have been shown to develop resistance mechanisms to that treatment that are potentially related to alterations in mitochondrial electron transport. So the rationale was really to combine this inhibitor with an already active combination of Decitabine and Venetoclax to attempt to increase its efficacy. So the study is a traditional phase 1b 3+3 dose escalation design. Patients are treated with OPB-11077 starting on day 1, and then Venetoclax and Decitabine are initiated on day 4. The dosing of the clinical trial drug, which I'll just call OPB from here on out, started at 150 milligrams daily in the first cohort, increased to 200 milligrams daily in the second cohort, and then to 250 milligrams daily in the third cohort. Venetoclax, as I mentioned, is started on day number 4, along with Decitabine, which is also started on day 4. Decitabine is given at 20 milligrams per meter squared IV daily for 5 days. Venetoclax is dosed at 400 milligrams daily if the patient is not on concomitant azole prophylaxis, and is dose reduced to 100 milligrams daily if they are. Response assessment occurs at the end of the 28-day cycle with a bone marrow biopsy, and patients who have stable disease or better at that time are able to move on to subsequent induction or maintenance treatment, which looks very similar in terms of dose and schedule. In terms of outcomes, we've treated 9 patients on the dose escalation cohort so far. Of those patients, median age was 73. As expected, all of these patients were older. 2 patients had newly diagnosed AML, and 7 patients had relapsed or refractory disease. 3 patients each were treated on dose levels 1, 2, and 3. Of the patients who were treated in the dose escalation cohort, 3 patients received 1 cycle of treatment, 1 patient received 2 cycles of treatment, and 5 patients received 3 or more cycles of treatment. We saw no dose-limiting toxicities in this cohort. The most common greater than grade 3 adverse events were febrile neutropenia, which was seen in 56% of patients, and muscle weakness, which was reported in 11% of patients. And no patients discontinued treatment due to adverse events. With regard to efficacy, the numbers are small, but in terms of best overall response to therapy, we had a complete remission in 2 patients, 1 with newly diagnosed AML and 1 with relapsed or refractory disease. 3 patients have died after completing study treatment, all due to progressive AML.